Hello, everybody. I hope everybody's staying warm. I'm coming to you from Nashville. Our power is out. There's about 200,000 people who have had their power knocked out, including us. Most of our clinics are out of power as well. So um, we're going to be talking about optimizing outcomes by identifying and treating dry eye. We did a Keratograph 5M study looking at this. One of the things that's kind of shocking me about clinic days now, I would say about 80% of our patients have dry eye disease. One of the things that I've been talking about lately is if you just are looking for it and you express glands on patients, you're going to find that they have meibomian gland dysfunction and they're making abnormal meibum. This becomes extremely important when you start talking about surgery, because as we all know, if you have a patient with dry eye and you do surgery before them, no matter whether you're doing cornea surgery, glaucoma surgery, cataract surgery, refractive surgery, blepharoplasty, oculoplastics of any kind, if you have a patient with dry eye, you're going to have some problems. I tell people dry eye is becoming such a major factor in what we do on a day-to-day basis. Forbes last year did a big article on dry eye disease and the treatments for dry eye disease. So I think it's very important that we start having some type of screening uh, technique and strategy to kind of pick up these patients. So like I said, I do cataract surgery, premium cataract surgery, refractive surgery, and then I don't do transplants anymore, but I do ocular surface extreme diseases like recurrent pterygiums, primary pterygiums. That picture that you see on the bottom, that is a recurrent pterygium that I had to do, where the punctum, if you're looking at the center of that cornea, that's actually the punctum right there. So she'd had two previous surgeries. This is post surgery after I worked on her. So one thing that we've been doing for several years is sequential bilateral cataract surgery. So now it's about 14 years that I've been doing this. And we wrote a paper looking at our results for sequential bilateral cataract surgery. These are mainly premium patients who are getting a premium lens, or patients who are paying out of pocket and don't have insurance. But one thing that you learn very quickly when you're doing these types of premium surgeries, or you're doing bilateral sequential, is that you better figure out any problems that they're having before you do the surgery. So if they have dry eye disease and you don't pick it up, then you're not only dealing with one eye that's having problems with dry eye postoperatively, but you're having problems with both eyes. And if you want to see somebody who's very upset, uh, do somebody bilaterally with cataract surgery and they're incapacitated with dry eye. So we need a way of diagnosing these patients that's not taking up too much of our time in the clinic. So we need something also that the technicians can do so that you're not getting time pulled away from patients. And if you look at the incidence of dry eye in cataract surgery, it can be all the way up to 80%. So we need something to pick these patients up, and we need something to treat them quickly so that we can get them on the schedule without any problems. So why is DED a problem with surgery? And in the answer is in confocal microscopy. So we have a confocal microscopy in our Nashville clinic and also in our New York clinic. We've had it for a few years. One of the things that we're learning with confocal is that if you see those,
we're a little misaligned.
If you see those little cells that were moving around, we now know those are T cells. So we have active T cells in our cornea that migrate, multiply with any kind of inflammation. So the cornea, we've learned, is a living, breathing organism. And anything we do to it, whether it's surgery or whether a patient has dry eye, it affects the cornea. So this is something on slit lamp you don't really see. The cornea looks clear. There's no SPK. There's no staining. But then when you look at the corneal confocal, you see these things. So one of the things I tell people all the time is the most specific inflammatory marker in dry eye disease is a T cell immunomodulator, which is interleukin 17. So T cells make T helper cells, and T helper cells make interleukin 17. So this video that I showed here, this is the work of Dr. Downey out in Australia, where she's actually showed these T cells. And we have confocals that almost look like a starry night because they're so inflamed because of dry eye disease. And when you look at the cornea is completely looks completely normal on slit lamp. Or you see patients who are complaining of severe neuropathic pain, and their cornea is not picking up stain, but when you do the corneal confocal, you see there's a big disruption in the corneal nerves. So the cornea is the most highly innervated structure per centimeter squared. If you're not familiar with a corneal confocal, this is kind of the pictures that we're taking. This is what normal nerves look like. That may be a little neuroma, which may cause some pain. But what normally a cornea nerve pattern looks like, this is called the corneal whorl. This starts inferior nasal, and then you get a high concentration of corneal nerves temporally that fan out and going up. So this is what normal looks like. But if you think of all the surgeries that we do, uh, it's going to disrupt these corneal nerves. There's so much of them. So let's just take a temporal incision with cataract surgery. You're making an incision here. Look at all the nerves that are going to be affected. So if you have a patient with dry eye disease that's undiagnosed and you haven't done anything to help their dry eye disease and create a better tear film, what you're going to see is these nerves will not come back normally. Let's think of a LASIK pattern. So LASIK pattern, you're making a laser incision and you may be going to the whorl, but again, you are disrupting these nerves. And we now know that the nerves are very important to create this tear feedback loop. So nerves tell the brain to create a tear. Tear tells the glands, the meibomian gland, the lacrimal gland, to create a tear, and here we go. So when you disrupt this with surgery, that could be a problem. Now, with a patient who doesn't have dry eye disease, or you've created a normal ocular surface and a normal tear, this doesn't play as much. But as we know, even patients who have no dry eye whatsoever and you do surgery, for the first few weeks, there can be a disruption because you've disrupted these nerves. Well, what have we seen with corneal confocal with surgery? So what we started to do is look at, and this is a video of what corneal confocal looks like. What you see is this is an incision. So this is a patient that was complaining of pain post surgery. He went to several doctors. Nobody believed that he had any problems because his cornea looked pristine. But when you do confocal, you see this scar. This is the scar of the incision, and you see interruption of nerves. So he had meibomian gland dysfunction, dry eye, surgery was done, and this is the result. And he did not get the normal healing across this incision site that you would normally see because the patient was a dry eye patient. So I'm showing you all this just to show the importance of screening these patients beforehand and treating these patients before you do any kind of surgery. So this is where the Keratograph 5M comes in, because it's a very important part of our screening for patients before any kind of surgery. What I'm doing more and more as I get further and further and becoming more of a dry eye specialist, almost every patient is getting a screening. It's very quick. The techs can do it, give you a report that you can use, and I'll show you what our study showed, what are the most valuable things to look at. And before you even walk in the room, you'll have information on whether a patient is a dry eye patient or not. So if you're doing surgery on them, this can be a discussion of Mrs. Jones, before we do this cataract surgery or this LASIK or anything like that, we're actually going to do some dry eye treatment to improve your ocular surface so that you can get the best results possible after surgery. So the Keratograph 5M can give you a lot of information. So tear film quantity, tear film quality, meibomian gland assessment, redness, and any kind of damage to the corneal surface.
Come to the same spot and blink normally.
So this just shows you a video on how quick this happens. So, you know, a lot of doctors say, you know, we don't really have time for this, to do these kind of screenings in the office. It's very quick. Patient comes in, they put their head in there, and in a matter of minutes, the technician can get a lot of information about their tear film, ocular surface, and things. So this is, you know, measuring tear meniscus. You know, the only time I really use a Schirmer's test is when we're doing a study, but for the most part, I mostly look at the tear meniscus to tell me if the patient is producing enough water. One thing I tell doctors as well is if a patient has meibomian gland dysfunction, one of the ways that the body compensates for the lack of fat in their tear is to produce more water. So one thing that I look at in somebody with meibomian gland dysfunction is this tear meniscus, and if they are not normal or above normal, it tells me there could be a problem, and we could have a mixed mechanism dry eye disease here. So the tear meniscus is playing an important part of what we're doing in the clinic. And then you get more information. You can get the non-invasive tear breakup time. What I found with non-invasive tear breakup time, and I did a study on this, you know, many years ago, because we were starting to use non-invasive tear breakup time for a lot of the studies, was what's the difference between a fluorescein reading and a non-invasive tear breakup time. I think the non-invasive is more sensitive. So what we found is usually a 2-second difference, meaning that if the non-invasive is 3 seconds, on fluorescein it's probably going to be 5 seconds. So I always just add 2 seconds to the non-invasive tear breakup time. So that gives you valuable information. Then, you know, more and more people are talking about Demodex and blepharitis. You know, what comes first, the Demodex blepharitis or the meibomian gland dysfunction? I tend to see that meibomian gland dysfunction happens first. You don't get those 2,000 molecules that keep the lid margin in check, keep our eye healthy. And what happens once you have meibomian gland dysfunction, then you get an overgrowth of bacteria and overgrowth of Demodex. So what I tell patients is these are normal microorganisms that live on your lid margin that are under control, but if you don't have a normal tear film, then they overgrow. And these, you know, we all have seen these patients before with pouting of the hair follicles. This is, to me, instead of scurf and collarettes and stuff, pouting of the hair follicle is actually the #1 sign for me in terms of Demodex demodicosis of the lid margin. And then lipid layer, just looking at getting a video of what the lipid looks like. It's like pouring oil on water. You can actually see that kind of oil slick because there's fat in the tear. And if you don't see that kind of oily tear, then you know that they're missing some fat in their tear film. And then redness. I think there's some patients that pain is their #1 complaint. There's some patients that dryness is their #1 complaint, irritation, decreased vision. But I've had several patients whose #1 complaint when it comes to dry eye is how red their eye is. And they tell me, if you can correct one thing, I would like you to correct the redness. The dryness doesn't bother me. The irritation doesn't bother me, the decreased vision, but the redness. So I famously had a board member of a multinational company who came in and he said, "Doc, you got to correct this, because when I walk into a meeting, they all think I either had a rough night last night or I'm smoking marijuana." So this was his biggest problem. So this is great to have a objective picture of their redness and then show them after treatment how much you've decreased this bulbar redness. And so this is a grading scale of the redness that you can use to show the patients how much progress they're making. And then meibography. So meibography, if corneal confocal is what's going on with the eye immediately, the meibography is what is showing you what is going on with the eye historically. So oftentimes when you see meibographies where, and this gives you a little bit of everything, where you have disappearing glands, you have glands with tortuosity, you have shortened glands, you have glands filled with abnormal meibum. These things don't happen overnight. So the way I use meibography is we have a baseline meibography, and then I tell patients we're going to start doing treatment, but it doesn't pay to do a meibography every month, because this didn't take a month to happen. This was over years that this meibography turned into this. So it's going to take at least 6 to 9 months for us to see a change in meibography. And so I actually tell patients it's almost detrimental to keep doing meibographies. I'd rather do it in a baseline and do one in 6 months or 9 months, because that's when you will, if they're treating and they're getting better, that's when you'll start to see changes, significant changes in that meibography. Now, if they want something more immediate in terms of seeing how your medications and how your treatments are helping their dry eye disease, corneal confocal. So we can have a patient that has starry night appearance on their cornea with inflammatory cells throughout the cornea, and then after about a month of treatment, if we redo the corneal confocal, we can see that starry night pattern down and those inflammatory cells decrease. In terms of nerves, corneal confocal, we've seen changes in nerves, and with specific treatments, seen it with platelet-rich plasma drops and with oxervate, and usually in 4 to 6 weeks, we can see a change in nerves of the cornea when we're treating a dry eye patient, especially when using those medications. If you're not using those medications and you're treating their meibomian gland dysfunction, and you're bathing that cornea with a better tear, it could take several months for you to see some changes in those nerves. So really, platelet-rich plasma and oxervate is a way to kind of kickstart normal corneal nerve growth. But you also have to do the treatments to help their meibomian gland dysfunction. So what is needed with these surgeries? So if you're like me, you have basically maybe a 2 to 4 week waiting time between the time that the patient is diagnosed with cataract, you take the measurements, and they get scheduled. So one thing that surgeons tell me all the time is, look, I don't have months and months to wait to help their ocular surface. A lot of these drops that patients use, so Restasis used to say, yeah, it could take 3 to 6 months for patients to see improvement in their ocular surface. We have newer medications now that it's faster, but we want something quicker so that we can tell the patient, yes, you're going to wait a little bit for your surgery, but we have some treatments to improve the ocular surface so that you have the best results. And what we were looking at is how can we use the 5M as a screening tool for dry eye disease before ocular surgery. This was done with Toyos Clinic and a Dr. Cruz in Puerto Rico as the 2 sites. And we did Keratograph 5M, and we were looking for what specific tests in the 5M showed and demonstrated to us that a patient had dry eye disease before we did fluorescein staining, looking at the cornea, meibomian gland expression, lid margin exam. So we're looking what could be a screening tool that the technician could do this 5N for you. They come in and say, hey, this patient has X, Y, and Z. They need to be put on your treatment protocol before we do surgery. And we looked at all the exams, and the 2 tests that correlated with our slit lamp diagnosis of ocular surface disease was a non-invasive tear breakup time of less than 10 seconds and more than 25% lower lid meibomian gland loss. So if you saw those 2 things, you're going to be treating that patient. So why is that important? It's going to save you a significant amount of time. So again, the biggest complaint that I got from surgeons is, look, we don't really have time to screen for dry eye disease, and we don't have time to treat these patients. We want to get the patients in and get them worked up and get them out and get them on the schedule. And I understand that, but they also say, yes, I do realize that for me to have the best results, especially when you're talking about premium and refractive surgery and oculoplastics and all of this, we're going to have to treat the dry eye. So technician gets this information, and if she sees less than 10 seconds of non-invasive tear breakup time and more than 25% loss of meibomian gland loss in the lower lid, immediately that's a patient we're walking into the room and going, yes, Mrs. Jones, you have a cataract. We're going to schedule you for cataract surgery, but we also have these findings from our Keratograph that shows us that before we do surgery, for your best results, we're going to have to treat your ocular surface disease and dry eye. So the question is, what is the quickest way to get their ocular surface improved? And I find the quickest way is intense pulse light, IPL. So you could also do drops, which we do as well, but it's a combination of whatever your favorite dry eye drop is, but IPL. And with 2 IPLs, I find that you can improve the ocular surface enough in most patients to get them to the operating room and do surgery. Now, if you have a patient with severe meibomian gland dysfunction, and their non-invasive tear breakup time is 1, and their meibomian gland dysfunction loss is 75% loss, yeah, that patient's going to take a little bit longer. But for most patients, I find 2 IPLs with expressions each time can get them tuned up in a couple of weeks and ready for surgery. And then you see there, this is something that I harp on a lot, and I don't know, all of the studies, all the FDA studies that I've done with IPL, every study that I've done post the first couple of years of IPL show that IPL with expression is a must. The FDA study that we did for IPL, we had sham IPL with expression versus IPL with expression. So even in those patients that just had expression, they showed improvement in signs and symptoms. And this is one of the reasons why, even if I see a dry eye patient who's not going to get IPL, is just a asymptomatic patient, I will still express their glands in the office because I know that'll help the signs and symptoms. But if you have patients that fail the Keratograph 5M in those 2 areas that I talked about, the non-invasive tear breakup time and the meibography, we'll do 2 IPLs with expression. So the Darwin IPL, well, the other thing I wanted to show you here is, and we'll get into it in a second, the thing I'm using for expression is the OCULUS lid stick, which is a silicone tip, very gentle on the conjunctiva, better than metal and better than cotton tip. This is the only thing I've been using for several years to express. You can express glands one by one. Has a hard little silicone area on the bottom, so you can actually get underneath the bottom of the meibomian gland and express up so that you can get full expression. But the IPL system, this is the Darwin IPL system. If you don't know much about IPL, the science behind it, it's not a laser, it's actually a gas lamp. It has xenon gas. If you go back to your chemistry days, remember xenon gas is here on the right of the periodic table. They are the stable, and we used to call them the noble gases when I was in chemistry, but the stable gases, they have the right number of electrons in its outer shell. When you put energy through that gas, it becomes unstable, but since it's a stable gas, it gets back into stability, and that releases a broad band of light, anywhere from 400 nanometers to 1,000 nanometers. The wavelengths of light that I find stimulate the meibomian glands to work better are the red, in that 600 range, 600 to 700. So what we do is we put a filter that blocks out the light below 600 so we can release that red light. And then over time, as the technology progressed, we realized that certain skin types cannot take all that energy at once, so we pulse the energy. So if you have somebody in the Fitzpatrick darker skin types, what you want to do is not give them too much energy all at once. You want to pulse that energy. So you give them a little bit, then give them some time to absorb that energy. We call that thermal relaxation time. So give them some energy, give them some thermal relaxation time before you give them another pulse of energy and then another pulse. So the most advanced IPL systems now have abilities to increased thermal relaxation time for the darker Fitzpatrick skin types, and you can pulse that energy and control that energy in terms of milliseconds, and then control the energy, the fluence, in terms of joules per centimeter. So the mechanism of action, there's several mechanisms of action in IPL. Kills bacteria and Demodex. Heat in the dermis so that you can melt the abnormal meibum and express it. So this is, a controversial thought, which shouldn't be. We know that heat has to be a certain temperature, 43 degrees Celsius in the dermis, for you to melt this thick meibum. So the best way to do that is not by putting heat at the epidermis, which can burn the epidermis and make it weak and make it more susceptible to bacteria and Demodex, but you want that heat to be in the dermis and not in the epidermis. And this is why we have cooling with the external part of the IPL system, so we're not burning the epidermis, so that these wavelengths of light are generating heat in the dermis to melt these secretions. So much better to have heat internally and not externally. The more heat you apply externally to the epidermis on this type of skin, the more you will get inflammation, breakdown of epidermis, and then more susceptibility to bacteria and Demodex. These wavelengths of light actually close the abnormal telangiectasia. So if you look at, this is a typical patient that we see where they've got these telangiectasias at the lid margin. These are abnormal telangiectasias bringing inflammatory mediators and choking, which will affect the gland, so you're not getting your normal meibum secretion. So one of the good mechanisms of action of IPL is that, and this is how I discovered it in the first place, was that it closes off telangiectasias. And what you'll find, it's not just the rosacea patients that have telangiectasias in their lid margin. And then we published a study showing that not only do we decrease inflammatory mediators on the skin, but we actually decrease the amount of inflammatory mediators in the tear film when we do intense pulse light. But the number one reason why IPL works to help meibomian gland dysfunction is photobiomodulation. These wavelengths of light stimulate the meibomian gland cells to work better by upregulating the mitochondria, stimulating the mitochondria to work better. And so photobiomodulation, you're seeing it everywhere. You're seeing it in age-related macular degeneration. They're using these wavelengths of light. They're using it in orthopedic surgery. They're using it in plastic surgery. Low-level light, which I'll get to in a little bit, is another treatment for meibomian gland dysfunction and dry eye. So light is becoming more and more important, and we are now learning how light can stimulate cells to work better. So this is, we're applying the IPL in two places. So with a small head, we can do IPL right on the upper lid, and then with a large head, we can go from ear to ear and treat trachea to trachea, treating nose, cheek, and people ask me all the time, why are we going ear to ear? I did a study way back in the beginning of just treating the lid margin, treating full face, and treating ear to ear. Ear to ear and full face works better. Why does that work better? We now know that these telangiectasias are a plexus of vessels that come from the nose over and from the cheek over and from the tracheus over. So when you do IPL from tracheus to tracheus, you're actually closing off more these telangiectasias. So you're getting an improvement in your efficacy. When I just treat it lid, those telangiectasias come back much quicker. And then to dispel any controversy of the upper lid, with the lids closed, you don't need to use internal shields. So what we found in confocal, when you do internal shields, whether they're plastic, metal, or even contact lens, it affects the cornea and increases inflammation in the cornea. The study I did and published on upper lid was without any internal shield. The other problem I see with internal shields is that when you put an internal shield, you're actually expanding that lid margin, and you may be getting less of the photobiomodulation effect because the meibomian gland is on stretch and can't absorb all of the light. And then this is just showing the use. I like the OCULUS lid stick because I can get underneath the lid, under the bottom of the meibomian gland, and express very easily. Just like anything else, this is a learning curve. So since it is silicone, it's going to be a little bit it's going to be slippery as compared to a cotton tip applicator. What I also like using the OCULUS lid stick is that I can apply pressure and then increase that pressure as I'm rolling up with the lid stick. And I find I get a lot more meibum with this than I would with a metal expressor or a cotton tip applicator. So what we're looking for in improvement, not only improvement in meibum, but this is what you'll normally see once you start doing IPL, is that you'll close off those telangiectasias. A lot of the reason why patients lose eyelashes is because Demodex will dive into the hair follicle. You're not bathing the eyelashes with its normal tear film and the molecules that are in the tear film, so you start losing eyelashes. But you can see you start closing off those telangiectasias, the meibum improves, the lid margin after expressions improve, so the lid margin looks a lot clearer, a lot thinner, more eyelashes. And then this is what I was talking about before. When I started IPL in the beginning, basically we were only doing Fitzpatrick type 1, and then I had to start thinking, well, if this is going to be a more wide range treatment for dry eye disease, it can't just be for Fitzpatrick type 1. And this is where pulsing energy allows us to do darker and darker skin types. So I've been able to do Fitzpatrick type 5, Fitzpatrick type 6 in certain instances by increasing the number of pulses, by increasing the thermal relaxation time. So this is showing you a pulse of energy of light. Then this is the thermal relaxation time. So you can actually increase thermal relaxation time when you get into higher Fitzpatrick scales. So by increasing pulses and increasing thermal relaxation time and decreasing fluence, we can start doing darker Fitzpatrick skin types. And you want a square wave pulse. You want the energy to be symmetrical in that pulse and not change. And you also want it so when you do your first shots to be 3 months later, that same energy. So if you pick a fluence for a patient and the pulse width and the thermal relaxation time, and you give them 10 joules, 3 months later, you don't want that energy level at 10 joules to only give you 9 joules, because then you have to start adjusting energy levels on a patient. So you want a stable energy output for a number of shots. And that's why you see some of the older generation IPL systems, you would have to change the bulb, the flash lamp, periodically, because what's happening is every time you would use it, the energy output that you would get would be less and less and less. So you'd have to change the bulb to get it back to its normal fluence strength per pulse. So this just shows you the protocol, and I've developed protocols for the Darwin. We're doing some shots on the upper lid. It's a 2-pass method. You can read all about that in my FDA studies. So you do upper lids, then you do trachea to trachea, and if you get a Darwin, they can give you my energy levels for all the different skin types. And so for the surgical patients, so we diagnose them with the Keratograph 5M. We put them on the dry eye treatment protocol, so you can put them on a FDA approved drop, or you can put them on a nasal spray, whatever your choice of treatment is for dry eye, and then schedule them for an IPL. And now if you have a 4th generation IPL system like the Darwin, you can do an IPL, wait a week, do another IPL, and a week later you can do their surgery. And then I would have them come in 1 month after they've healed from cataract or refractive surgery, and do another IPL if necessary.
Oh yeah, that's a good one. Very satisfying, isn't it? Yeah. Kind of depends on who you're talking about.
It is satisfying to express glands and get all that junk out. You feel like you're accomplishing things when you do that in your clinic. So for a Chalazion, I always get asked this. What do I do for a Chalazion? I do 2 or 3 passes with a small tip right at the Chalazion. I'll do an expression. I'll give them a steroid antibiotic drop to use for 4 days, for 4 times a day. And then I usually bring them back in a few days and I do it again. I find that protocol of 2 IPLs back to back, just at the area of the Chalazion with expression, usually takes care of the problem. And then if you know, I've been using low-level light treatment, and this is my patent on the low-level light treatment for, it's now 16 years. And so the newest one is a red light and infrared Q. And this is low-level light treatment that the patient can do at home. We actually sell, this is a medical device, so we sell it to doctors so they can sell to their patients. So if this is something that you're interested in, low-level light for your patients, you can call our office and we can train you on how to train your patients in low-level light, and this is something that you can get to your patients. If you don't want to do that, patients can call the office, do a telehealth where we do training and get them on the medical record, and then we can have them use the red light. It's very interesting now because patients just ask me, well, is this doing any damage to my eye? And now we know that red light is being used and is FDA approved to decrease the risk of macular degeneration. So these lights are actually good for the eye and the retina, and they're not bad for the eye. And then if you're doing IPL, you can use it for other things. You can use it for rosacea. You can use it as a photofacial rejuvenate the skin, because red light actually stimulates fibroblasts to make collagen and elastin. You can use it for melasma or brown spots, and you can use it on acne. So IPL is very versatile, and you get this for dry eye, but you'll find that you'll use it for medical aesthetics, and if not on your patients, you'll definitely use it on yourself or on your staff. They'll want IPL photofacials to improve their skin, and this is becoming more and more, I don't want to say acceptable, but more and more routine, where people are realizing that the best way to take care of their skin is not wait for their 60s to get a facelift, but to do maintenance treatments of things like IPL and other skin treatments to improve and maintain their skin, instead of waiting until everything is sagging, there's no more collagen and elastin left, and then going through drastic treatments to try to rejuvenate their skin. We have a Saturday teaching clinic in New York City, so we're usually there every Saturday. And if you want to spend the day with us seeing dry eye patients, that's available to you. Just you can text me or you can call our office. A group of dry eye specialists internationally. We started the Dry Eye Society of the Americas. Our first conference is this year. Membership is free, so DESA membership is free, and it's going to be a great conference. We've got a lot of different speakers from the dry eye world, speakers from other walks of life to talk about up and coming treatments that you may not think are for your dry eye patients and your normal patients, but patients want to know about exosomes and peptides and nutrition. And so we've got a wide range of speakers lined up for this conference. It's going to be in New York City. There's a Friday night mixer, July 10th, and then the conference is going to be all day long, July 11th. Be aware that this is during World Cup, so you want to register now and then start looking for your hotel rooms now. But there's going to be a lot of excitement in New York during this time, and I'm looking at the lineup that we already have for the DESA conference. It's going to be something special. So you don't have to fly off to Europe or Asia to get a good grounding basis for how you're going to treat these dry eye patients and how you're going to screen for these dry eye patients. You can get it all here in the US. That's it. I was told I had 45 minutes, and we can maybe take some questions if there's some questions.
Wonderful. Well, first off, I just want to say thank you, Dr. Toyos, for taking the time out of your evening to share your expertise with us. Those workflows, tips, tricks, and on even just a personal level, the confocal microscopy images are pretty incredible. That corneal whirl is pretty cool to see presented up like that. So thank you again. We do have some questions here, and I'll just run through a few of them with the time that we have left. So the first one, I'm just going to kind of combine a few of them together here. And are there any dry eye patients, you spoke about the Fitzgerald skin types maybe, for example, but are there any dry eye patients who should not receive IPL prior to cataract surgery?
Yeah, Fitzpatrick, I wouldn't, if you were just starting with IPL, I wouldn't do Fitzpatrick over 4. I would get some experience before you do Fitzpatrick type 5 and 6. Now you have low level light treatment that you can do on every Fitzpatrick scale. It's about 1/3 the energy of IPL, so it's not going to be as dramatic. You may have to do maybe 3 or 4 low-level light treatments, 1 a week before they're ready, as opposed to 2 IPL systems, IPL treatments, because it's lower energy, but it is energy, and it can get the ocular surface in those patients who are type 5 and 6 tuned up before surgery. IPL in the African American population, especially if they're over a type 5, can be dangerous. So again, that's for the experienced IPL user and not for the beginner.
Perfect. Thank you. Now, kind of segueing off that, I guess, in some capacity, you mentioned a little bit about that follow-up IPL procedure post-operatively, if necessary. What's your workflow for kind of determining if that's necessary, the patients that get it, and is there a blanket wait time after a procedure, or does it vary based on the procedure itself, be it laser vision correction or cataract surgery?
Yeah, so 1 month, no matter what kind of corneal surgery they've done. So whether they've had, I don't do DSEC or DMEC anymore. We refer that out. But after a month, after 1 month, after a DMEC, I would do that. After 1 month of cataract, after 1 month of any corneal refractive surgery. I've had patients with shunts and dry eye. Actually, one of the videos was a patient there. I would have no problems doing a IPL 1 month after a shunt procedure or glaucoma procedure. Retina procedure, I would probably wait 3 months if they had retinal detachment or something like that. I would wait for the retina surgeon to clear them before you do any IPL. And it's signs and symptoms. So if I see that the meibomian gland, and this happens a lot with patients after surgery, whether they've had dry eye or not, that feedback loop is affected from the surgery. So I think doing a 1 month IPL and expressing the glands is always helpful. If you have any patients that have any symptoms of dry eye or complaining of dry eye, but if I see signs or if the patient is complaining of symptoms, doing a 1 month IPL can save you a lot of heartache and trouble and patients using a gazillion drops. And it'll optimize your results with that patient.
Wonderful. Thank you. Now, we did just have one here actually just coming in that was submitted saying that they see dry eye worsen in these post-surgical patients. How do you go about getting the buy-in prior to surgery, the kind of pre-treatment, to help them understand the value of the outcome and the result prior to that surgery?
See, actually, that's a great question. I should have covered that a little bit more. Patients are very visual. So if you can show them the tear breakup time and go, look, your tear breakup time should be 10 seconds and longer. And here, let me show you the sheet. This sheet is telling us that, and this objective test, not me, this objective test is telling me that your tear breakup time is abnormal. And then you show them pictures of their meibomian glands, and you go, and we have this in each room. We show what normal meibomian glands look like, and we go, look, this is what normal looks like. This is what your meibomian glands look like. You have dropout. You have 25% dropout. You have tortuosity. So visually, I think showing them. And again, you don't necessarily need this, but always showing video of what's coming out of their glands or what their lid margins look like, or pictures, that's helpful too. So in our rooms, we have video set up and pictures set up, but you could, if you wanted to, you could take a snapshot of a picture off the Keratograph, because sometimes I'll do that as well. If the tech hasn't printed something out for me, I'll take some pictures off the Keratograph, bring it in with me on my phone, and then I'll just go over very quickly with the patient. That's sometimes when we're super busy and I want to save some time.
Excellent. Thank you very much. And with that, I believe we will go ahead and call this a night. Thank you again, Dr. Toyos, for, again, sharing your insight with us this evening, your expertise, and for all these pearls. I know this is one that will probably get a lot of watch back when it's posted here in the near future. So for those that registered, you will get a recording of this session sent to your inbox within the next few days. It is posted to the Oculus YouTube channel within a few days after that. But above all, we just want to thank you all for joining us this evening and for tuning in. And thank you again, Dr. Toyos. And I hope everyone has a
Thanks.
great night.
Everybody stay safe. Thank you.